Bismillahirrahmanirrahim. Hi everyone. In this video I will be giving some tips that hopefully will help the new intern acquire this important medicine art fairly quickly during the residency training. The art of presentation. An art that is needed almost every day during residency and is crucial for physician development. Now let's see if you as an intern can do the mic drop after your presentation so that the attending has nothing else to ask or add. That should be your goal, and that's what I tell my resident to aim for during their presentation. I will do my best to make this video short and informative, so let's start. So why is it important? And as you can expect, the presentation skills is really crucial for the development of any learning physicians, and there's many reasons that this could be really crucial. So for example, one of the 6 ACGME core competencies is interpersonal and communication skills. So residents are being evaluated for that competency, and you need to make sure that you present in the right way that most of the other doctors, most of the other physicians communicate and present their case. Also, a good presentation reflects good clinical reasoning, and the attending will not really know what's in your mind and how you are interpreting the data that you have unless you present that in a very reasonable and organized way. So it's part of assessing your clinical reasoning skills as well. And also, good thorough presentation also reassure your attending that you really know what you're doing, and you did your diligence in terms of the assessment and plan, and in that regard you can get good evaluation to make sure that you are meeting the requirement for the next step of your development and milestones. And also it facilitates smooth knowledge sharing, right? So if you present your case in a very organized way, I can know exactly what you're trying to say, and that's also very important for good patient care. So when do you need to show your presentation skills? To be honest, I think it's gonna be almost every day during residency. So there are 2 big areas that you'll need these skills for. The first one is as you're presenting your case during daily rounds, whether it be in the inpatient setting or the outpatient setting, presenting a case coming to the clinic, or presenting a case to a subspecialist if you're doing an elective. And the second one is presenting a topic in a lecture or a formal presentation. I will focus more on the first one. I think the second one is really we can have another separate video talking about that, and what are the tips that can be helpful. But I will still talk about it briefly at the end of the video, but I will focus more on the first one, which is how to refine your presentation during daily round, especially during the inpatient rotation, since I'm a hospitalist. So before I get into details, these are just some general advice that I think apply not just to presentation around or medicine. I think it applies to presentation in general, even during lectures and all that. So for example, you really want to make sure that you be organized during your presentation and follow a specific structure that you're attending or your program wants you to follow, and you're gonna develop your own way as you present more and more, but always try to follow a specific structure, be persistent. That will make you less likely to miss important points in your presentation, and make sure you delivered all the important data to your team and attending. Don't rush your presentation. Speak clearly, speak slowly. You want to make sure that your team and your attending heard all what you did to your patient and all what you have thought about during the workup for your patient. Body language is always important. For example, don't give your back to your team or to your attending while you're presenting. Try to make eye contact, especially whenever you're presenting an important data or fact. and that really makes audience engage in your presentation. Also, adjust your tone as you're presenting, especially if, for example, if you're presenting an important piece of data, you want to kind of draw the attention of the audience and the people in the room. Also, if there's something that sounds funny, presented in a funny way, that will make your presentation not really tedious or monotonous. It will make it more interesting, and it will engage other your colleagues, your co-resident into your presentation and as well, and that will make the will create more healthier environment for discussions. So these are general tips. Again, there are probably more, but probably these are one of the most important ones. So let's start with presenting a new admission. Most of the time in the inpatient ward, you're going to be called by the ED, or your senior will be called by the ED for a new admission. So you will have some data already beforehand, before you even see your patient and get some more detailed history. But in general, I think your goals for this type of presentation is really to tell the patient story in an organized fashion. And I'm saying patient story because, as you know, many parts of the history really needs to be presented in the patient's own words, because that makes a lot of difference a lot of times. But again, also you need to kind of add your own taste to it as you're presenting. And then you want to make your point for your assessment and plan, right? I mean, by the end of your by the end of taking the history and doing the exam and looking into all the data and discussing with your senior, you should come up with a decent differential diagnosis and a working diagnosis. So it's reasonable to tailor your presentation according to that particular final diagnosis or potential diagnoses, because that will make the presentation more structured, and it will just make more sense. So the first part is, of course, the HBI, and it's really important that you pay attention to this, because I think for me, HBI is really kind of the most important part of the presentation. It's really why the patient is here, and it has almost most of the data that you will need for getting the appropriate diagnosis, if not all. Sometimes it's all what you need in some cases. So yeah, pay a lot of attention to that. You're probably going to see some information in the electronic health records before you go and see the patient. But again, don't be biased by that, and always go and talk to the patient. Start with open-ended questions. Don't ask 2 or 3 questions at a time, and try to get the patient story, why they really came to the emergency room, and start to sort out the timing, which symptoms started first, followed by what, and for how long, and this kind of things. This is really kind of the basics of HBI, and you're probably all aware of it, but sometimes when you really get busy, you might tend to forget some of these basic stuff, but it's really very helpful if you stick to this basic structure. So yeah, I can't emphasize that more. Pay attention to the HBI, and usually during the HBI presentation, I encourage my resident to start with the pertinent past medical history. So for example, you say this is a 39-year-old African-American gentleman with history of ischemic heart disease, heart failure with reduced ejection fraction, and diabetes mellitus, who presented today with worsening shortness of breath. This is, for example, in comparison to saying 39-year-old African-American patient coming with shortness of breath. In the first sentence, the differential is a little bit narrower, and of course, heart failure will be probably on top of the presentation just by saying that. in the second sentence, you still have a very broad differential. I mean, you're going to consider a wide differential anyways, but as you present your HBI in a certain way, that will help the listener build their differential diagnosis as you add more and more. All right, and then you probably mentioned a lot of the past medical history there, so or at least the important one. And then you're just gonna ask about the review systems. Hopefully in the HBI you already included the systems that are part of the differential diagnosis. And then for the review systems, you just added the other system that are less relevant, but you want to know about them anyways, just to make sure that there is no other data that we're missing. And also to get to know your patient as well and make sure there is no other problem that maybe the patient is not willing to say at the beginning. And then you will add other less pertinent past medical history or past surgical history. But again, make sure that the important part of the past medical history and past surgical history, which are important in the HBI, make sure that these are already in the HBI at the beginning of your presentation. And then the rest of the history, which includes the social history, the family history, and the drug history. Also, sometimes you might omit some of these if they're not really relevant at all to your case, but you're probably going to ask about them anyways. And then you're going to present your vital signs at the beginning of the physical examination, and then you're going to start your exam by the general exam, and then you can start with the system involved, or you can defer the system involved at the end, whatever you like. And then you're going to pay attention to not just the positive, but also the pertinent negative, which implies that you really know what you're looking for. And all this is based on the HBI and the differential diagnosis that you're telling your team or the audience during your presentation. And then you're going to mention the labs, starting with CBC, CMB, and then the pertinent labs. And also you want to not just mention the numbers, you want to tell your own interpretation of these labs, so that you tell your attending that you know what you're looking for. You're not just really reporting, but you're also assessing and dissecting your data. So try to tell if this is really, you think it's high, it's low, it's really low, it's really high. And that's will make your presentation more impressive. And the same for images. And you always try to suggest that you want the team to look at the image, not just to read the report. So that's really important, and I really encourage you to do that. Always try to look at the image yourself, do your assessment, and then go over the report by the radiologist. And then the emergency department course, you can mention that before your assessment and plan. Or some people might actually say add that to after the HBI. And both are fine. I personally like to my resident to say it after they finish their history and before they start their assessment and plan, just to kind of emphasizing the fact that we don't want to be biased by what happened in the emergency room per se, but of course this is important part of the history, so it also makes sense to present it earlier. And then the final part is assessment and plan. So you want to give like a line or two about summary of the case, and then you want to indulge into the number one problem, the most important problem, which most likely will be the main reason that the patient came to the hospital. And then you want to make sure your differential, and then you want to present or re-emphasize the data that support your differential, and you want to mention that the other differential and why they are less likely. And then you go to the next problem, and to the next problem, and to the next problem. Always remember, as a hospitalist, you are the kind of the primary care provider for your patient in the inpatient setting, so you want to cover most of the important problems that pertains to their admission. And then at the end, you can just mention the other common stuff like the DVT prophylaxis, nutrition, in any structure that you prefer, but you have to cover the important inpatient bullets that we usually look at for every single patient in the general medical wards. So this is kind of a general frame that I suggest for you to follow for specifically for when you do a new admission. So here is an example of how you can frame your assessment and plan at the end of your note, and also when you're presenting to your attending. So it starts with kind of one paragraph that kind of summarizes the case with the important and pertinent positive and negatives. So for example, you can say something like 50, so here we have a 51-year-old male with history of CAD, heart failure, diabetes, and chronic kidney disease, who lost his job and insurance 2 months ago, who is now presenting with progressive shortness of breath over the last few days, associated with lower extremity swelling and fatigue, without a chest pain, without a fever. He was tachycardic and borderline hypotensive, with hypoxia at 87% on room air. And he also had a JVD and basal crackles and grade 3 lower extremity edema on examination. So this kind of summarizes the case, and it's actually it's clearly what you want to tell the attending or the audience, right? You're clearly directing them towards what you're thinking, which should be the next step. So you start to mention the problems one by one, of course, starting with the most important one. So in this case, for example, shortness of breath slash acute hypoxic respiratory failure. And then you mention what's your assessment of that problem, what's causing it, what's the severity, what's the underlying etiology, and just a general assessment. So you can say something like, likely due to CHF exacerbation due to poor compliance as a result of inability to refill medications after he lost his job. He's now on 3 liters nasal cannula with some moderate respiratory distress on exam. This is unlikely pneumonia. There's no fever, no leukocytosis. For example, you can put that in parentheses, or new ischemia. You can also say, he doesn't have chest pain, no ischemic changes in ECG, and troponin was 0.04. So you're clearly picturing, the status of this main problem. We have a clear image about how the patient looks like even before we go inside the room and look at the patient. So that's very useful. And then after that, you can present your plan. So we're going to admit the patient for telemonitoring because his potassium was low. We're going to admit him to the general medical floor. I ordered low salt diet. We're going to initiate him on furosemide, 40 milligram twice a day, with a small dose of lisinopril at 5 milligram daily, and a small dose of beta blocker with carvedilol 3.125 twice daily. We're going to monitor his vitals, obviously. We're going to titrate his oxygen supplementation. Hopefully it will go down. I also ordered strict input and output, and also daily weight to see his response to the diuretics. And also we'll order daily electrolytes, and we'll replete as needed, especially the potassium. So that's, as an example, really, makes attending sure that you really covered most of the important aspects of the plan related to management of acute CHF exacerbation. And then after you're done with the first problem, you can go to the next problem, the next one in importance, and then do the same thing. Assess the severity of that problem. What's your goal with that problem? What are you going to do about it? Which would be in the plan, and then you go to the next problem and the next problem. And usually at the end, we always talk about like DVT prophylaxis and disposition, like when do you expect the patient to be discharged and where. So this is just kind of general frame. Of course, there might be like some different formats, but this is kind of the general principle, not just during presentation, but also like as you write it in your note. Now, what if you're presenting to the attending next day or like down the road during your daily assessment of the patient. Here, of course, the presentation is expected to be a little bit quicker and shorter because the attending and the co-resident, they know the patient already. So your goal to be really kind of highlight the pertinent events and how the patient is progressing and how is he responding to your treatment, and also you want to follow the same structure, which is usually the SOAP, starting with the subjective, objective, and then the assessment and plan. So usually, if you're attending, said, okay, let's talk about Mr. M, and then you're the one who's following the patient. Then you can start with a one-liner if you want, or you can go directly to the overnight event. So you can say something like, Mr. M, he's our 51-year-old male patient who was admitted 2 days ago with shortness of breath with the diagnosis of CHF exacerbation, for example. And then you say something like, overnight, he started to have some chest pain. He was evaluated by the night team. They ordered some ECG and troponins, which came back negative. His chest pain is really, when I talked to him this morning, and that will bring us to the next, which is kind of subjective. So you basically gonna present your encounter with the patient. So you're gonna say something like, when I went to see him, he looked comfortable, but when I asked him about the pain, he said it's gone now. He doesn't have any chest pain at that moment, and he said it was like just overnight, a little bit of kind of a sharp pain, and he pointed to where the pain is, and when I pressed on it, it hurts a little bit, and he denied to me any other symptoms at all, and he actually said he's feeling better. So you're just really telling the audience, kind of the subjective evidence of how the patient is progressing. So this is for the S, and then next is the objective, like a more clear and evident data, and that will include the vital signs. Maybe with some trend, you want to mention that, oh yeah, his heart rate is actually getting better today compared to yesterday, and he's actually only requiring 1 liter of nasal cannula. So he's getting better in that perspective. So you give your assessment of the vital signs, and then on examination he looks more comfortable, less crackles. His edema is now 0.1 plus, and he was able to lie flat a little bit for some time, and then he had to raise his bed again. The rest of the examination didn't change, for example. So this is kind of the next step. This is part of the objective data. And then you mentioned if there's any change in the labs or images. So his potassium today is normal. His creatinine is still stable. He lost about 2 liters with the diuretic dose that we gave him. There's no new images. We didn't need to repeat the chest X-ray. And you can mention the ECG, which was done overnight, and the troponin, which was done overnight, were unremarkable. And then you mention your assessment and plan, and then it's going to be mostly what you presented already on admission, but of course, sometimes you need to change the first problem. In this case, maybe you want to mention that the first problem is the chest pain. So as you said, you mentioned your assessment of that. So you said something like, his chest pain is really central. It's increased with palpation. It's very localized, very sharp, and for a few seconds. I don't think it's really ischemic pain. His ECG and his troponin were negative without ischemic changes. So that's a good assessment. And then you just mentioned, so I know I put him on some acetaminophen as needed for the chest pain, and if he had poor response, I will add lidocaine batch or something. And then you can mention the second problem, which is again the heart failure and acute respiratory failure, and then you mention your assessment and plan accordingly. So this, if you keep that format, if you keep that structure persistently each time you present, it's going to be like a second nature. It's going to be much quicker, and you're going to be more fluent and efficient in your presentation. Now, let's say it's Monday and there is a new attending on the service. and you're still following the same patient. And now you have to present your patient to the attending, who doesn't have a background about the patient. So it's very similar to the progress note that you have been doing every day, but this time your goal is really to kind of summarize the previous hospital course since admission, and also after that you continue with the SOAPs, right? So this is really kind of the main difference. Is really how you're able to summarize the case to the new attending, since you're supposed to be the one who really knows the patient the best, because you have been following the patient every day since admission. So you want to mention like why the patient came to the emergency room, what was the main diagnosis, for how long he has been admitted, and why he still needs to be admitted, what exactly we're doing, and why the patient is still here. So for our patient, you can say something, we have Mr. M, who had a history of CAD and heart failure and CKD, who came in with shortness of breath 3 days ago. We diagnosed him with CSF exacerbation. He had been responding well to the diuretics, and initially he was hypoxic, but now he's only requiring supplemental oxygen intermittently, and he is feeling much better today. And then this is really puts a good picture about your patient to the attending. And then after that, you can start with the same structure as if you're presenting a regular progress note. So you can start with the overnight event, and then you're gonna do the SOAP, subjective, objective, and assessment and plan. And clearly you set the floor at the beginning to mention that the patient is obviously seems like he's almost about to be discharged, and that will be an important part of your assessment on that day. So this is kind of the main difference, is really how to acquire the skill to kind of be able to summarize your case. And that's really very important, because you really want to summarize it in a way that really tells the story, but you don't want to give unnecessary details. I mean, this is at the beginning, it might not be easy, but again, if you really practice that every time you present your patient to someone who does not know the patient, then that would be very helpful, and it will be much easier for you. You can do the same thing when you're like signing your patient to the night team. If they have a new overnight team, they don't know the patient, this is the first time you're gonna sign out to them, then you can also practice these skills and see if you can really summarize the case really well to them, so that they can have a good picture about the patient. Lastly, I'm going to mention some of the tips that hopefully will be useful. And these tips apply when you're presenting a case to a bigger audience. It really depends on the setting, whether it be like a formal setting, like you're asked to present or participate in a presentation of a grand round, for example, or like a research or a QI project or something like that, to a really bigger group in the hospital, or a little bit of an informal presentation, like you're presenting to your peers, to your group, to the other resident, your morning report, M&M, these usual classes that usually do some discussions with internal medicine residents. So again, many of these tips were mentioned before when we started to talk about tips for presentations in general, and that included being organized, and to speak clearly and slowly, and not rush your audience. And also in most of these presentations, you really want to be a little bit brief than the a more detailed presentation when you're admitting a new patient, for example. You really want to present only the most important data, the pertinent positive and the pertinent negative, because usually it's the time is limited, and you want to have more time for discussions. Also, I really highly recommend that you pause and try to think about a catchy introduction to your presentation before you start. So in that way, you can get the attention of the audience early on, and they will be listening to you tentatively more. For example, if you're presenting a morning report, you can start by saying something like, this is not like a rare case, but there is a very important new information that I want to discuss at the end of the end of the presentation, and I'm hoping that this information will help you during your daily work, because it's not uncommon, and you're most likely gonna encounter that during your daily work, something like that, just to kind of try to come up with something that's kind of catchy. Also try to always engage your audience as you're presenting. And you can do that by many ways, eye contact again. You can do it by asking questions intermittently. You actually can also use enhancers, and that also increase the engagement of the audience. For example, I like to use Poll Everywhere, a very useful app. I usually create my questions in that app, and then I ask the resident to answer the question. It's very nice and well organized and user friendly, and it's also anonymous, so the resident will feel comfortable answering all the questions because they will not be identified. It's just kind of a way to get them engaged in the discussion, because that's really key. And you can be creative about it. You can come up with your own ideas or like use another applications. Okay, we came to the end. So please, if you have any questions or any suggestions, just send me an email or write a comment below. And thank you all. And I really hope that these tips were helpful, and I really wish you good presentations. And thank you very much. Bye bye.